Hello and welcome to our seventh lecture covering mood disorders and suicide. We're going to first start off by just understanding what we mean when we use the term mood disorder and defining the basic types of disorders within this category within the DSM-5. So we're really talking primarily about the dichotomy of depressive disorders and bipolar disorders. We're going to talk a little bit about the prevalence of these various subtypes of mood disorders. We're going to talk about the likely causes based upon, our integrated theory we've been talking about. So we'll talk about various different approaches and models for understanding mood disorders and how we can integrate them into a more comprehensive sort of multidisciplinary view of looking at it. And we're going to talk a little bit about treatment of mood disorders as well, including both medications and therapies and other various aspects of treatment. Finally, we're going to talk about the phenomenon of suicide, which is not technically a disorder, but is certainly something that we need to discuss in the context of abnormal psychology and is most typically associated with mood disorders, which is why it's included in this chapter as well. So let's get started. I want to start off with an overview of essentially these two poles of a concept of mood disorders, depression and mania. So when we talk about a mood disorder, I want to reiterate this sort of dimensional continuum approach we've been talking about throughout the entire class. As you remember, we've discussed how previous versions of the DSM and psychology in general in the clinical field had been very prone for many, many years to a sort of categorical diagnostic model or theoretical viewpoint that said you either had or did not have a disorder. And for many reasons, we've come to try and embrace a more dimensional continuous approach about these various symptoms. The reason being is multifold. First and foremost, the research shows that people do experience subsyndromal degrees of a lot of these symptoms throughout their lives, whether it's normal amounts of sadness or anxiety. We also know that it doesn't necessarily help patients to be categorized as other than, to be seen as somehow qualitatively different from people without these disorders. In fact, the very concept of saying someone has or does not have this disorder is something we really need to be careful about how we say it and how we utilize it. Ultimately, we want to focus on people's humanity first and foremost, but we also want to appreciate that these things all exist along a continuum. That also helps us to differentiate one person with a disorder from another due to degree of severity or the type of presentation that we see. So all in all, the idea is to recognize that there's a normal spectrum of mood in human beings. We all have some degree of variation in our mood. What we start to see as disorders, as we discussed in early chapters, is deviations from the norm, and arguably relatively extreme or gross deviations from the norm, if you will. So we're talking about people that meet some sense of being a bit of an outlier from, let's say, the normal bell curve, the normal distribution of how people tend to experience their mood. And what's interesting about mood disorders, which is somewhat unique from other disorders we're going to talk about, is that we really have two sides or two poles that we're discussing. So when we talk about a mood disorder, we're speaking about gross deviations in the direction of both depression and of mania, which is kind of the opposite of depression in some ways. So when we talk about mood disorders, they're composed of these different types of episodes of moods. And this is, again, something that's kind of unique to this chapter and this part of the DSM that's going to be unlike other things we're going to talk about this semester. Because what the DSM does and what we think of diagnostically is we have the concept of episodes, which is sort of an active phase of the deviation in mood, and then the disorder is defined by the presence of these episodes plus a few other specifiers, a few other criteria that we use to diagnose someone with the disorder. So first and foremost, we need to talk about what the episodes are, because the episodes are kind of the key ingredient, the key building block of the larger diagnosis of the disorders. So we're going to really discuss basically three types of of episodes. Major depressive episodes, what we classically think of when we think of clinical depression, which is, a term that's not technically accurate anymore, but it's certainly the way many people still think about depression. Manic episodes, and then sort of this subtype of manic episodes called hypomanic episodes we want to be aware of as well, which are somewhat distinct. They're qualitatively distinct from mania in really important ways. So these are the three things, and these are just, brief definitions of each of these would be: a major depressive episode obviously is a period of depressive mood. A manic episode is a period of severely elevated mood as opposed to depressed. Again, our language is very powerful, but essentially what we're saying is we're using the term elevated to mean above the norm and depressed to mean below the norm. So there's a certain imagery involved in this as well. And finally, just briefly, which I'll go into more detail, but a hypomanic episode is a period of less severely elevated mood than you would typically see in a full-blown manic episode. So let's start with a major depressive episode. As I said, this is something we used to refer to as an episode of clinical depression. What we mean by clinical in that context is likely requiring, or at least would benefit from, treatment. But when we define it in terms of the DSM, we're looking at the idea, and we'll talk about the actual criteria from the DSM on the next slide, but we're looking at something that can really be thought of in two separate ways. And these are actually the first two symptoms that we talk about when we're diagnosing a major depressive episode. And when I, am assessing someone in my clinical practice, this is the two sort of major points that I'm looking for. And what's interesting is that you have to have one of the two to be diagnosed, as you'll see in just a moment. But so these are core essential symptoms of depressive episodes, major depressive episodes. The first is extremely depressed mood. And so let's define what we mean by that, because it's a little vague and people have different connotations of that phrase. Essentially, what we're talking about is the mood experience, what we all generally refer to as being sad, down, blue. There's tons of language that we use to describe this type of mood. But essentially, I think sadness is the core emotional experience that we're talking about here when we talk about depression. So, an episode with extreme depressed mood so again, you can have both or you can have either, the phenomenon what's called anhedonia. So anhedonia is a word that technically means one of two things. A loss of pleasure in life is the typical connotation. But what it can also mean is that you're continuing to engage in activities that you used to find pleasurable and you don't get any pleasure out of them, or you may have withdrawn or ceased those behaviors. So it can kind of take a couple of different manifestations when you think about anhedonia. Just to reiterate that. So on the one hand, it could be that you're continuing to do all of the things you used to do, many of which or some of which used to bring you pleasure or joy, and now they're not. They don't seem to be working. The other side of that is that you may have withdrawn from those activities. You may have pulled away from those activities. So those are sort of our two key concepts I want you to keep in mind when we think about a major depressive episode: is extremely depressed mood and/or anhedonia. And this is not something that is acute and fleeting or passing. When we're talking about extremely depressed mood in the terms of a major depressive episode, it needs to be significant. It needs to be pervasive and persistent. So the terminology that's utilized, we often discuss within the clinical practices are: does it last most of the day? Is it nearly every day? And has it gone on for at least 2 weeks? So these are all sort of arguably arbitrary indicators of what's significant. But when I talk to patients about their depression, about their PTSD, about their anxiety, I sometimes utilize the frame where I say, look, this condition that you have, that you're suffering with, especially if it's based on chronic, aspects of your life that are not going to change, like your health, it's not getting better, that kind of thing. I like to remind them that we don't always measure our success or our progress by the absence of this thing, in this case, depression, altogether. We have to look at it utilizing meaningful metrics, and those metrics are typically intensity, frequency, and duration. So the idea being, how bad is it? How intense is the depressed mood, for example? How long does the depression last? Does it just hit you for an hour or so and then you feel better, or does it go on for, all day, or the better part of a day, or most of the time? And then, has it been going on for more than just a discrete window of a day or two? Is it persistent enough that it's been going on for at least 2 weeks, which is sort of where we draw this arbitrary line of significance. In addition to that, we're going to talk about a lot of the physical and or cognitive symptoms that accompany depression, some additional criteria that you need to meet to be diagnosed with a major depressive episode. And this can take a lot of different forms, and we'll go through all of them in the next couple slides. But indecisiveness, we sometimes talk about avolition, which is the loss of motivation, difficulty starting activities, feelings of worthlessness, extreme fatigue, appetite changes, either good or bad. I shouldn't say good or bad, either increased appetite, beyond normal, or decreased appetite. Restlessness or feeling slowed down. Again, either side of the spectrum. Sleep disturbances, of course, insomnia is another symptom that we think of associated with depression. So let's look at the actual criteria from the DSM-5. And again, whenever I have these slides that demonstrate the actual criteria from the DSM, you're going to notice they're very busy. The font is very small. I apologize. You can find these things in your book as well. And of course, they actually are available online. Or if you happen to have a copy of the DSM, then you, of course, will have access to this. And for those of you that are interested in a career in clinical psychology, or who plan to continue as a major in psychology with a focus on clinical work, then it might be valuable to pick up the DSM. As I said, you can get this sort of desk reference version, which is much less expensive, or you can get the full-blown version, which is sort of a paperweight, a big purple book that looks just like this in larger form. Includes a lot more detail and a lot more information about the research that led to the diagnoses when the committees at the American Psychiatric Association were developing these criteria. So let's dive right in. As is the case with a lot of the way, well, virtually all the symptoms and syndromes within the DSM, there's usually some threshold. And so we allow for variance in expression and individual differences by saying not everyone's going to fit perfectly into the same mold. And so you don't have to have all of these symptoms. And in fact, you have to have some combination of these symptoms. And typically what we are looking at when we see things like 5 or more is it enough to feel you capture the syndrome? As another aside, very briefly, let me mention what this means for diagnostics for a lot of people is that you may meet a lot of the symptoms for a diagnosis, but not enough to meet the full-blown diagnosis. Does that mean that you don't have a quote-unquote disorder, or that you're not having trouble, or that you're not distressed, or you might be having impairment in your functioning? Absolutely not. Frequently, I will see people that are kind of subsyndromal, is a term that is often used. They have significant symptoms of the diagnosis, but not enough to fully meet the criteria. What we'll notice is that there are some other diagnoses, sometimes some minor versions of these conditions that might be more appropriate. But I just want to be clear, this is something that's decided by committee based on empirical evidence, but it is not absolute. It is not gospel. So we know that we are prone to biases, and we know that perhaps these criteria may not capture everyone and may not fit everyone's individual expression. That being said, these are the ones that are agreed upon and are in the DSM, and as I said, are based on a lot of research that is shown to be valid and reliable. So let's get back into these symptoms themselves. You need to have 5 or more of the following symptoms, and this is just the first page. We're going to have a subsequent slide. I believe there are 9 total, depending if you count them all up and depending how you number them. But basically, you have to have 5 or more that have been present during the same 2-week period. Again, that has to have some duration and represents a change from your previous functioning. And so that's an interesting point, right? Is that if you were meeting these criteria for a long period of time, it wouldn't be a new diagnosis of a major depressive episode, but you still might be meeting that criteria. Maybe it's one long depressive episode. So we are looking for, though, something that shows a deviation from normal feeling or mood. And as I mentioned in the previous slide, you have to have either symptom 1 or symptom 2. So these are considered necessary symptoms to meet the diagnosis. There's a small note here: do not include symptoms that are clearly due to a general medical condition or mood incongruent delusions or hallucinations. This is just a qualifier that is based upon a couple of things. One is that there are a lot of health conditions that can mimic depression, and we'll touch on that as we go through these. The second is that you may have a patient who is psychotic due to schizophrenia or some other factor that would allow them to present with odd mood, manic mood, or depressed mood, but in the context of a delusional belief or a hallucination. I want you to worry too much about that, because this is obviously a very common diagnosis. The things I'm referring to as far as mood incongruent delusions or hallucinations are quite rare. So depressed mood most of the day, nearly every day, as indicated by subjective report. As I said, how do you feel? This is where you simply can ask a patient to tell you. And if they say they feel sad or empty or down or blue, then generally speaking, we consider that valid evidence of this significantly depressed mood, as long as it meets that criterion of being of a duration of 2 weeks or more, or observation by others. This is really interesting, because sometimes we have people that may not have the emotional vocabulary or the willingness, or even maybe in some sort of denial or lack of awareness of how they feel, and be unable to report the subjective mood, but people around them clearly see indicators of this. In some cases, for example, the person feels tearful if they have a constantly dysphoric sort of affect, depressed affect, the way they look, lack of eye contact, moving very slowly, just kind of appearing very lethargic and tired. So in children and adolescents, a lot of times the children may not have, at least especially children, may not have the vocabulary or the sense of self to define their mood as depressed. Adolescents are probably a lot better at that, but even then there may be some difficulty. And also in the case of children and adolescents, it may not necessarily present as overt sadness. We noticed through research that there tends to be a more likely presentation of irritability as the dominant mood in children and adolescents. But nevertheless, we think that's sort of an outward expression of depressed mood in this context. The second criterion is the markedly diminished interest or pleasure in all or almost all activities, most of the day, nearly every day, as indicated by either subjective account or observation made by others. Again, there's that option for other people to observe this. This is the anhedonia symptom that I was talking about. And I think that this can be a more subtle and more insidious and potentially more crippling symptom of depression. I've had several patients throughout my practice. Some of this may be due to their age and their lack of comfort with talking about mental health issues. But who would say, I wouldn't really say I'm depressed, because they have a very specific connotation of that word, perhaps someone who's suicidal or who can't do anything because they're so depressed. But then they'll start talking, and in that conversation, it'll come out that I've stopped doing the things that I used to do, or that I'm not getting any pleasure or joy out of life, out of the things that used to give me those things. So anhedonia, I think, can be easier for some people to handle than the actual label, with all of its potential stigma of depressed, sad. Either way, you have to have one or the other of these two symptoms. The third symptom is significant weight loss when not dieting, or weight gain. And we're defining that by a change of more than 5% of your body weight in a month. So that's one possible indicator. We call these vegetative symptoms, physiological symptoms of depression. Or you can just simply have a decrease or increase in appetite nearly every day. This is one of those examples of how a physiological symptom or a vegetative symptom of depression can go in either direction to excess. I have people who are depressed who will lose weight, who will stop eating. But based on the research, we assume due to anhedonia, due to someone who is no longer getting pleasure out of eating. They're not enjoying their food because they're generally not enjoying much of anything, and so they stop eating. As a result, they may lose weight, or you don't have to necessarily even lose the weight, as long as you subjectively report decreased appetite nearly every day. And then it can go the opposite way, which is people who are potentially trying to cope with their depression or who are seeking pleasure in a desperate way, will eat more and more. And they may even focus on eating particularly unhealthy foods with, high sugar, high salt contents, because of that sort of quick hit of, neurochemistry that comes with eating some of those foods. So some alteration to a significant degree in the person's appetite is another symptom we associate with a major depressive episode. In children, one way you can think about it is, are they failing to make their expected weight gains for their age range, like during their annual checkups? The fourth symptom that I want to discuss is insomnia or hypersomnia nearly every day. This is another example of sort of the polarity of a vegetative symptom associated with a major depressive episode. So you've got someone who is having difficulty sleeping or is sleeping too much. We often sort of investigate people's sleep by asking questions about maintenance and initiation of sleep, and that's kind of the most two common ways we see insomnia. Either somebody is having difficulty falling asleep, initiating sleep. This may be due to rumination on negative aspects of their life. They may be ruminating on stress or anxiety provoking things that are going on, worrying about things the next day, whatever it is. That rumination may be preventing them from falling asleep because of that negative arousal going on in the brain. Or the person might be able to fall asleep, but not be able to stay or remain asleep or maintain their sleep. And so they're waking up frequently. They're not getting long periods of sleep so they can cycle through those healthy stages of sleep, including REM sleep, which we need for brain health. And as a result, they're waking up frequently and they're not getting rested. They're not feeling rested when they wake up. So those are kind of typical manifestations of insomnia. Insomnia is quite common in depression, but also common is the reverse in some people, which is hypersomnia. Hypersomnia, just by, if you break the word down pretty directly there, is sleeping too much. And people might be sleeping 16, 18, 20 hours a day in some cases, even in extreme cases. So what you're seeing is, some alteration to an extreme nearly every day in the person's sleep-wake cycles. And again, vegetative symptoms, physiological symptoms associated with the mood. The next symptom is also sort of a physiological symptom. We call this psychomotor agitation or retardation nearly every day. Polarity, okay? This is going to happen a few times here in the definitions or in the symptoms of depression. Psychomotor agitation or retardation. Let's break that down. Psychomotor involves both your psychology and your physiology movement. What we're talking about here is that the person may feel restless or agitated. What's really interesting is when I talk to people that I work with in my practice, if I say, "Are you anxious?" they almost always take that, a lot of them take that to mean physically nervous, jumpy, trembling, shaky, restless, full of energy, nervous energy. When we say anxious, as you know from this class so far, we really mean more worry, right, in the mind. But there is a physical manifestation of depression that can be that sort of restlessness, agitation, subjectively feeling like you just got all this energy that you got to get rid of and you can't seem to shake it. The flip side of that, the polarity, which can be extreme, is what's called psychomotor retardation. And this is when the person feels like they're slowed down. Some people describe this as like, you're walking through sludge or you're moving through water instead of air in your daily life. Just kind of as a subjective experience. In very extreme cases of depression, psychomotor retardation can be really kind of shocking to see. You'll most likely, if you ever observe this in a clinical setting, you probably are going to see this in a person who is in a psychiatric hospital for depression. This is typically only seen where it's really obvious at extreme levels, but it goes along a continuum. And so some people might just notice that they're just feeling like they're moving a little, like slightly slower and just not being as quick to get things done physically. But when it's extreme, it's pretty phenomenal. You'll see people who, it's almost as if their brain is slowing down, is moving slowly. When you ask them a question, they will take a long time to appear to take in the information, and then it might take them an inordinate amount of time to calculate a response, and even their speech might be slowed down. So I might, be on inpatient psychiatric unit and say, Mrs. Brown, how are you feeling today? And Mrs. Brown might take a full, long pause before responding, and she might say, I don't feel very well today. Okay, so very slowed down, lethargic in some ways. And that's sort of an extreme example, but essentially what we're getting at is a polar disturbance in your energy level, either too much or too little. Tied to that, of course, is the feeling of fatigue, loss of energy nearly every day. Many people with depression say they feel tired all the time and fatigued. And this can be one of the more debilitating but subtle symptoms of depression for a lot of people. Simply just feeling a lack of energy and being unable to get things done can turn into this negative feedback loop where you're not meeting your responsibilities, and therefore you're starting to feel more like a failure or struggling in your functioning. So fatigue should not be underestimated as a really crippling symptom in depression. The next symptom, the seventh symptom, is more of a cognitive one, which is feeling worthless, experiencing excessive or inappropriate guilt, which may be based on no evidence, therefore delusional, nearly every day. So this is not merely mild self-reproach, being a little tough on yourself, or feeling guilty about being quote unquote sick. In this case, if you're identifying your depression as an illness, we're talking about excessive, inappropriate. So you might characterize this as the excessive or inappropriate guilt as someone who's really beating themselves up. And they may be beating themselves up over things that are not even necessarily rational. They may be judging themselves very harshly without reason. Related to that in some ways is a feeling of worthlessness. And so is the person feeling like they have no value as an individual, as a human being. Worthlessness is often, to me, one of the key symptoms that reinforces and keeps depression going, along with helplessness and hopelessness. And we'll talk about helplessness in a minute. But I find that vicious combination of those three symptoms in my patients can really indicate a more significant or a more serious or severe depressive episode. The eighth symptom is diminished ability to think or concentrate, or indecisiveness nearly every day. Again, either by the person's subjective account or observed by others. As I mentioned, people who are really depressed sometimes feel like they're slowed down physically, and the same often holds for their cognition and for their thinking. So they might be saying, I just can't seem to keep everything straight in my head. I can't seem to remember things. I can't pay attention. These are all common complaints of people in the midst of a major depressive episode. The ninth symptom, of course, which relates to our discussion of suicide later in this chapter, is recurrent thoughts of death, not just a fear of dying, but thinking about death in a way that's, intrusive, recurrent suicidal ideation without a specific plan, or a suicide attempt, or a specific plan for committing suicide. Now, this is not the healthiest grammar in this ninth criterion here, but let's walk through it. People who are depressed are not just afraid of dying, they are ruminating upon death, their mortality. We'll talk a little bit about this in our subsequent discussion about suicide in part 2 of this lecture, but I do think that this is a common, ruminative touch point for people when they're depressed, is coming back to the idea of my own mortality, my own death. What would that mean? As you can imagine, and as we'll discuss, for some people, they're seeing their death as a possible escape from the significantly depressed mood they're experiencing, because it is painful. It's aversive, emotionally painful to be going through something like this. And we have a natural desire to escape, to avoid things that are painful. In some cases, the person is only experiencing suicidal ideation, which means thinking about it. They might not even be thinking that I want to die per se. They may just be thinking about their death. In my patient population, amongst elderly patients, it is very common to see passive suicidal ideation in the absence of a real full-blown major depressive episode. It certainly occurs within a major depressive episode, but passive suicidal ideation is thoughts like, if I just died of natural causes tomorrow, that would be okay with me. That might actually be the best solution to my problems. Or if I went to sleep tonight and didn't wake up, I'd be okay with that. That's really passive suicidal ideation. Active suicidal ideation is more the thought that I want to die, or I'm thinking about what it would be like to die. That's sort of the, and we'll discuss this in greater detail and later in this lecture, but or in part two. That's the lowest sort of level of severity of suicidality as a concept. And then we start talking about intent. I want to die, and I intend to do something to bring that about. I intend to hasten my death in an active way. And then finally, having a plan, having something in mind that you're going to, conceivably do to end your life. Certainly, a suicide attempt can fulfill this criterion as well. So those are our 9 core symptoms of a major depressive episode. And as is the case with all of the diagnostic criteria in the DSM-5, you also have to have the inclusion of symptoms B and C here. They cause clinically significant distress or impairment in the person's social, occupational, or other important areas of functioning. Remember, it's not a disorder. If it does not cause you distress and if it does not cause you impairment in functioning, it begs a really interesting question: could someone meet 4 or more of these diagnostic criteria? I'm sorry, 5 or more of these diagnostic criteria, and not necessarily meet the criteria for the larger episode, not necessarily be considered depressed. I don't know, it's hard to imagine that scenario, but it's certainly possible. But if it's not causing the person distress and it's not impairing their functioning, then according to the DSM, they're not in the midst of a depressive episode. And then lastly, the symptoms are not due to direct physiological effects of a substance or a general medical condition. And you'll see right in here, listed as an example, is hypothyroidism. I believe I did mention in one of the previous lectures, so I won't reiterate the whole story. One of the very first patients that I ever saw as a practicum student in my first year of clinical psych grad school was a woman who was profoundly depressed by appearance. You talked to her for 5 minutes, you said, gosh, this person is really, really depressed. She was court ordered to seek therapy. She had lost custody of her children in a divorce. The divorce had been predicated by her apparent horrible depression was part of the issue. She was failing to care for herself. She was not caring for her children. But part of the court order also involved she needed to be evaluated by her primary care physician, by a doctor, a physician. And as it turns out, she had incredibly low indicators of her thyroid functioning. She was in the midst of what's called hypothyroidism. And someone who has hypothyroidism looks profoundly depressed. They look lethargic and tired. They often are displaying psychomotor retardation. They may be sleeping all the time. They may stop eating. They generally may stop caring for themselves and appear to have, difficulty concentrating. And to an outside observer, they look very, very sad, at least in extreme cases. What was really fascinating, though, was that this woman was started on levothyroxine, a medication that boosts up your thyroid functioning or your thyroid levels in your body, and she was a different person when I saw her subsequently. It was really staggering to see. So before you diagnose someone with a major depressive episode, there are certain medical conditions that need to be ruled out. In a relatively healthy younger person, these things are rarer and less important to do exhaustive testing. You can just go based on the likelihood of things, but you should never rule them out. And it often is a good idea if you're a clinical psychologist or another mental health provider and you start seeing a patient for the first time to make sure that they've been evaluated by a physician recently, at least for a basic physical. If you have specific concerns based upon their presentation, you might say, hey, I want you to go to your doctor and ask them to check your thyroid levels or other things you might be concerned about. Of course, a person who's abusing a substance, especially central nervous system depressants like alcohol and sedatives, the benzodiazepines, drugs like Klonopin, Xanax, that kind of thing, can certainly induce a major depressive episode, and they often will look like someone who is depressed under the influence of those drugs. So that's a major depressive episode. Let's talk about the opposite end of the pole here with a manic episode. So manic episodes are defined by elevated or expansive mood for at least 1 week. So I come back to this theme in the class about how I want you to think of these symptoms along continuums. I want you to understand that people that meet a diagnostic a diagnosis are not necessarily that dramatically different from the average person, that we do all experience some degree of these symptoms. I think with depression, it's easier for the average person who's never been clinically depressed to understand, because sadness is such an inherent feeling. It's part of the spectrum of human emotions. We all experience loss. We all experience disappointment. Mania, when it's in a clinical form, when it meets criteria, is elevated and expansive in a way that often looks and to, based upon the report of patients, feels very different than just being in a good mood. But all of us experience a good mood, at least hopefully you have those experiences in your life to one degree or another. But if you imagine for a moment, if you think about a time in your life when you were in a really good mood, this idea that just you didn't focus on anything negative and you were very optimistic and you were very willing to say yes to things. Well, if you take that feeling and you amplify it to an extreme level, you start to get a sense of what we mean when we say elevated, expansive mood. So when it goes extreme, when that manic episode starts to be present, what you see is a syndrome that in some ways is the reverse of some presentations of depression. The person experiences, rather than worthlessness, inflated self-esteem, to the point of being grandiose in some cases, thinking that they are inherently special in some way. Decreased need for sleep is the most dominant, most prevalent symptom you see in a manic episode. Somebody who just says, I don't need to sleep, I don't feel tired, and they may not sleep for extended periods of time, which has its own physiological problems, which can only serve to exacerbate the manic episode sometimes. Excessive talkativeness. Now, as y'all are very aware by now, after watching this many of my lectures, I tend to talk very quickly and expansively. That's just the way that my brain works, I guess, the way that I express myself. But when you're talking to someone in the midst of a manic episode, the speech is constant. There's not a lot of natural pauses. And it often will display what's called flight of ideas, or which is indicative of racing thoughts. Flight of ideas is where the person is jumping from one subject to another, sometimes in what appears to be an entirely unrelated fashion. Sometimes they're engaging in what's called circumstantial or tangential speech, where they're just making these somewhat arbitrary connections from one topic to the next and just going and going and going. And it can be that classic presentation of someone speaking very rapidly, very quickly, without a lot of pauses, without stopping to listen. The person may subjectively say, it feels like my thoughts are racing. They're going a mile a minute. I can't rein them in. They are easily distractible. So this is where it can share a symptom of depression, difficulty concentrating. But this is sort of the phenomenon. We often, unfortunately, we sometimes have, as a culture, we joke about ADHD, which we're going to talk about down the road. That whole joke that's become prevalent of squirrel. The person's attention is diverted very easily. Well, in this case, the person is easily distracted by anything, and often just things that are vibrant, things that have a lot of energy or sound around them, or quite literally, they can get distracted by things like lights, noises, that kind of thing. You see an increase in goal-directed activity, or psychomotor agitation. Again, the person is physically moving very quickly. They're animated, they're restless, they're all over the place. The increase in goal-directed activity is really fascinating because people who are in the middle of a manic episode may report that they are being extremely effective. They're getting everything done. They're going above and beyond with their responsibilities or their projects. What the reality often is that they are not completing projects and they are not doing them very well, but there is the sense that you're being incredibly productive. This can start to veer into some really extreme examples, and mania can involve some degree of psychosis, which we're going to talk about in a minute, which is delusional beliefs are part of that. But you're also likely to see in a manic episode excessive involvement in pleasurable but risky behaviors. This can be driving your car too fast, risky sexual behavior, like sex with multiple partners without protection, and or in dangerous circumstances. Certainly drug and alcohol abuse can happen during a manic episode, which can become very cloudy to differentiate between what's the substance and what's the manic episode. But typically, if the mania precedes the excessive involvement in the behavior, then the drug use, that is, then you can make that distinction. Gambling is very common. There's probably nothing worse than a person who's in the middle of a manic episode who's also in a casino. This ability to just kind of, it's pleasurable. You're getting a little high, you're getting that dopamine kick during the activity, and people will often go way and beyond their means in the process and end up in a lot of trouble. And then impairment in normal functioning, right? Because again, there are people that kind of are, let's call it, non-clinically manic, subsyndromally manic. I'm sure you know someone in your life who has a lot of energy and a lot of nervous energy and might have this sort of this expansive mood, but functions well and is not crossing that threshold to a degree that it's really impairing them in their functioning. That's just the nature of some people's personalities. So the one thing I wanted to note is that this has to last for at least 1 week. You can diagnose a manic episode if it has lasted less than a week, if the person has ended up being hospitalized as a result of it. And people very frequently are hospitalized in a manic episode. I'm going to speak in a little bit about the misapplication and misdiagnosis of bipolar disorder. I'll come back to that. But oftentimes if someone says, yeah, I think I've been kind of manic, my first question is, were you hospitalized for it? Because a full-blown manic episode almost always involves hospitalization, stabilization, and sort of titration of medications to try and get that manic episode under control. So in a way, if the person is being hospitalized, which is limiting their activities, and or they're being medicated, and that leads the manic episode to last less than a week, you can still diagnose this if it meets the other criteria. So let's jump a little bit forward and look at the actual DSM-5 criteria. As I said, a distinct period of abnormally and persistently elevated, expansive, or irritable mood. Okay, so let's stop there. In some people, the mania is not expressed as a brightness, as a positive energy, but rather the person is extremely irritable and in an angry way, but it still has that sort of abnormally elevated feel to it. The person is like really aggressively angry and has that high energy output. Abnormally and persistently increased goal-directed activity we mentioned, or energy, and lasts at least 1 week and is present most of the day, nearly every day. We want this to be a persistent, really present symptom to meet this criteria. And then again, of any duration if hospitalization is necessary. During the period of the mood disturbance and the increased energy or activity, you have to display 3 or more of the following symptoms. 4 if the mood is only irritable. This is really to make sure you don't misdiagnose someone as bipolar who's manifesting only the irritable side of this. These symptoms have to be present to a significant degree and again represent a noticeable change from your usual behavior. The first is the inflated self-esteem or grandiosity. Grandiosity is sort of the belief that you have special importance, powers, that I am, not just sort of normal high self-esteem or even, just normal great narcissism, but rather a really inflated sense of self-importance. And it can even reach some really delusional levels where the person might believe that they're the only person that can, find a cure for cancer. Or, if you think about someone in the midst of a manic episode, one of the kind of classic anecdotes is somebody who's climbing the fence at the White House because they have to talk to the president because they know how to, stop the pandemic, or they have some, manic belief, some delusional belief about their ability to do something miraculous or special. Decreased need for sleep. So feeling rested after only 3 hours or less of sleep is kind of that's one benchmark, but it can vary. More talkative than usual, or they have that pressured speech where they're just feeling like they've got to get it out. Flight of ideas or subjective experience that thoughts are racing. So as I said, this can be internal, or it can be manifested by the person speaking in that very distinct flight of ideas way. Distractibility, which is essentially difficulty concentrating, where your attention is too easily drawn to unimportant, irrelevant external stimuli. This again can be reported by the person or observed. And then that number 6 is that increase in goal-directed activity. This can be socially, at work, at school, or sexually. Psychomotor agitation, which is like this purposeless, non-goal directed activity just bouncing off the walls, so to speak, might be a good way to think about that colloquially. The 7th criteria is excessive involvement in activities that have a high potential for painful consequences. Unrestrained buying sprees, very common in manic episodes, like so running up tons and tons of credit card debt. Sexual indiscretion, investing in business ventures that are foolish, that are clearly not good ideas or scams, that kind of thing. This mood disturbance has to be sufficiently severe to cause significant impairment in your social or occupational functioning, or necessitates hospitalization to keep the person from harming themselves or others. Or there can be psychotic features. So let's break that criterion down a little bit. The first part is just the impairment criterion we've talked about a lot. It has to impair your functioning. What you'll notice is there's not a lot here about distress. That is the really fascinating thing about someone in the midst of a manic episode. Not everyone who is in the midst of a manic episode thinks there is anything wrong with them. In fact, most people in the midst of a manic episode think that everything is great. In fact, everything is wonderful. And they don't understand why you can't see that. So there are some people who have a degree of mindfulness or awareness, especially as the manic episode starts to come down, that they are behaving in an unhealthy fashion or that something is wrong. But many, many people in the midst of a manic episode think everything is wonderful and will not seek help. So this is the emphasis on impairment in functioning rather than subjective distress. That's the first part of this. The hospitalization, again, is very common. People that are experiencing a full-blown manic episode will often need to be hospitalized to prevent them from harming themselves or someone else. And then finally, if there are psychotic features. So I don't want to get too deep into the weeds on this because we have a whole other chapter we're going to talk about. But when I use the term, or whenever psychologists use the term psychosis, they are essentially referring to one and or the other of these two symptoms. Okay, the first is hallucinations, perceptual disturbances, seeing, hearing, feeling, smelling things that are not there. Hallucinations can take really any form of your senses, but the most common are auditory or visual hallucinations. You do also see olfactory hallucinations, tactile hallucinations, that kind of thing. But most commonly what you're going to see is hearing voices that are not there or seeing things that are not there. And this can occur in the context of a manic episode. The other aspect of psychosis is hallucinations or delusions. And delusions are firmly held irrational beliefs. Delusions can take various forms. The most common form of delusions that you see in a manic episode are what are called grandiose delusions. That's that inflated sense of self-esteem. And when it becomes delusional, it is the kind of thing I mentioned earlier, like there is something not only special but magical about me, something incredibly important about me. I'm the only person who can solve a very important problem, or I have some special place or meaning in history. I have some destiny to fulfill, that kind of thing. Delusions can take a lot of other forms. Paranoia is probably the most common form of delusion most people are familiar with. People are out to get me in an irrational way. It can be all manner of other types of kind of eccentric, bizarre delusions. You can think, that there are aliens that are monitoring my thoughts, or the CIA has put a chip in my brain and is controlling my behavior. I've been invaded by nanobots that are affecting my physiology. There's all these kind of, really sort of bizarre. You think of the kind of ugly classic stereotype that people used to have about someone who was psychotic. They would say, this is the guy with a tinfoil hat. Well, generally what's going on in that is a delusion of thought intrusion. The person thinks that someone is either monitoring or controlling their thoughts in a delusional manner because they're psychotic at the moment. And, this idea of tinfoil is perhaps this somehow blocks the waves that are being used to do so. Again, that's kind of I think probably an overused stereotype, but it allows you to get a sense of how a person might feel in the midst of a delusion. So mania is one of those places where you can see psychosis, either in the form of hallucinations and or delusions. Um, a few other qualifiers that you typically see in a lot of these sets of criteria. The episode is not attributable to the physiological effects of a substance or another general medical condition. A lot of times the substances we associate with pseudo-manic episodes, right? Someone who looks like they're having a manic episode are the stimulants. So amphetamines, methamphetamine, that kind of thing is what you typically associate with it. There is a note here the DSM wants you to be aware of, that a full manic episode that emerges during antidepressant treatment, so someone who's getting, for example, Prozac or something in that class, or is undergoing ECT, but persists at a fully syndromal level beyond the physiological effect of that treatment, is sufficient evidence of a manic episode, and therefore what's called a bipolar 1 diagnosis. We're going to talk about that and clarify that in a moment. The issue here is that in some people that may have a diathesis towards bipolar disorder, experiencing mania, they may be sort of thrown into a manic episode by use of antidepressant medications. In a sense, the pendulum swings too far the other way. Perhaps that increase in serotonin is actually what is at a neurochemical level responsible for the mania. We're not absolutely sure about that. But if you then remove that medication and the person is still meeting the criteria, and it's out of their system for a manic episode, then you can go ahead and make this diagnosis. If it goes away, then you have to be careful about whether or not this was actually a manic episode brought on by an underlying disorder, or if it was simply brought on by the effect of the medication. This can also be observed occasionally with ECT. Now, ECT is rare in and of itself, and people being thrown into a manic episode as a result of ECT is even rarer than that, but it is one of the rule outs you have to consider in the DSM criteria. The third type of mood episode that I want to discuss is a hypomanic episode, which is essentially a less severe, often shorter version of a manic episode. So it has to last at least 4 days as opposed to a week. It has fewer and milder symptoms. It's usually associated with less impairment than a manic episode. That is, less of the sort of like excessive spending or risky sexual behavior or sort of thrill seeking that can be dangerous. And it may, in and of itself, may not be problematic. It's not. This is again an example of the continuum of these. I'm sure that many of you have had times in your life where you were probably bordering on a hypomanic episode, where you were extremely productive and just kind of were in a zone and in a groove and working really well. But when it reaches a clinical level, it usually occurs in the context of a more problematic mood disorder. So in and of itself alone, it may not be representative of a disorder, but it typically is regarded as just a less severe form of a manic episode, and it's almost always devoid of the sort of psychosis and really sort of delusional aspects you see in more extreme manic episodes. Now, there are other episodes of mood episodes that are called mixed features. And this is where you kind of have a discrete period of time where there is elements of both mania and depression that, reflecting opposite valences of mood. But you can have a depressive episode that may have a few manic features, or you can have a manic episode with some more depressed or anxious features. So to think of some examples of that, you might have someone who is really depressed but is not sleeping at all, has that sort of classic manic episode, lack of need for sleep, doesn't feel they need to sleep. Or you might have someone who's in the middle of feeling manic but also then has this, maybe vacillates back towards something we typically associate with depression, like feelings of worthlessness, and then the difficulty concentrating, again, is kind of an overlapping symptom. Certainly the insomnia is an overlapping symptom. So there are episodes where things feel like they have a bit of both, that are best captured by the concept of an episode with mixed features. Generally speaking, we've got these episodes, right? These types of mood episodes, but then we have the larger mood disorders. The same way that a panic attack was a symptom or a discrete, psychological phenomenon that can occur in the context of panic disorder, obsessive compulsive disorder, phobias, whatever, social anxiety. The same thing can be said of these sort of mood episodes. They are a primary core component of a larger mood disorder. And we generally break these down into two categories: unipolar versus bipolar mood disorders. The term unipolar, meaning only one extreme of mood is experienced, is when there's only depression or only mania. Now, the occurrence of someone who has only mania with no episodes of depression at all is actually pretty uncommon. It is much more common to have depression with no mania. In fact, statistically, as we'll see in a little bit, in part 2 of this, I believe, we'll talk about prevalence rates. Bipolar disorders, manic episodes are much, much rarer than unipolar mood disorders of depression or major depressive episodes as well. Bipolar mood disorder is the name itself, right? There implies the two sides of the poles. So meaning that there's both depressed and elevated moods are experienced often in a cyclical fashion. And those cycles may take long periods of time, or they may be very brief, which we'll talk about in a minute. There used to be a specifier with bipolar disorder where we would say rapid cyclers. It was a type, a subtype, people that would be going from between mania and depression in a matter of weeks even, whereas it's much more common in a sort of a more classic presentation of bipolar 1 disorder for the person to have prolonged, long depressive episodes and then these spikes of mania. So there's a lot of different ways in which these presentations can combine with one another, but we often will break them down into unipolar and bipolar mood disorder. A couple things to think about for a moment. Classically, in previous forms of the DSM, I believe you have to go back to DSM-3, bipolar was not the term that was used. They were called manic depressives or manic depressive disorder. The individuals were often called manic depressives. And there's a Jimi Hendrix song called Manic Depression, but the idea is that they were right there in the name. They were indicating that it included aspects of both mania and aspects of depression. So that's that bipolar aspect of it. Now, in terms of the unipolar or depressive disorders in the DSM-5, we basically have 4 disorders, 4 diagnoses: major depressive disorder, which is kind of the classic example of what we used to call clinical depression. The other one is persistent depressive disorder, which is a new name for an old diagnosis, which we'll talk about in some detail. And then new to the DSM-5 are 2 other diagnoses: premenstrual dysphoric disorder, or PMDD, and disruptive mood dysregulation disorder, which is a mouthful. So these are both new diagnoses that we'll talk about each of them in just a moment. So when we diagnose someone with major depressive disorder, what we're basically saying is the person is having one or more of these major depressive episodes that are separated typically by some period of remission. And we generally will distinguish them between single episodes, which is pretty unusual, and recurrent episodes, which is more common. So the takeaway from that message, unfortunately, is that having just one single episode of depression that meets the full criteria for a major depressive episode is actually relatively uncommon. Most people that experience major depressive episodes will experience more than one. And again, there's tons and tons of variability in how these things are expressed, but that's one of the qualifiers that you'll see in a moment within the DSM criteria is you specify single episode versus recurrent. So here is our very packed slide with the DSM-5 criteria for major depressive disorder. So right there, letter A, the first thing I want you to notice is at least one major depressive episode. And again, we've talked about that already in this lecture. Criterion B is the occurrence of the major depressive episode is not better explained by any of the following. Now, these are all different diagnoses within the DSM. So major depressive disorder might be considered the pure form of depression, whereas we now know major depressive episodes can occur within the context of lots of other disorders. This is, again, very akin to the concept I presented in the anxiety chapter about panic attacks. Panic attacks can occur within lots of different diagnoses. You can see people with social anxiety, with panic disorder, of course, and with other types of anxiety disorders, OCD, that are manifesting panic attacks. If in this case, if the major depressive episode is better explained by another diagnosis which captures that major depressive episode, then you do not diagnose major depressive disorder. And the examples that are given here, all of which we are going to talk about through the course of this class, are schizoaffective disorder, schizophrenia, schizophreniform disorder, delusional disorder, or some other specified and unspecified schizophrenia spectrum or psychotic disorder. What they're essentially getting at here is that the family of disorders that surround the illness that we call schizophrenia essentially often has a component of depression in it. And so we're trying to differentiate individuals who have that diagnosis from people that are more purely depressed. The criterion C here is there's never been a manic or a hypomanic episode. The reason being, this is not a unipolar major depressive disorder. It would become something in more of the bipolar family that would better capture the presentation and the experience of that individual. So there is an exclusion here if all of the manic-like or hypomanic episodes are substance-induced or are attributed to the direct physiological effects of another medical condition. So again, we're talking about, ruling out intoxication under stimulants, that kind of thing, or some other medical condition that can cause symptoms of mania or hypomania. This could be anything like hyperthyroidism could cause that. Certainly some delirium, some infections or drug reactions can cause, this sort of what looks like mania in some situations. And of course, if it's caused by cocaine or methamphetamine, stimulation, and that's the only time the person's displaying manic episodes, then of course you can make this diagnosis. You specify the clinical status and the features of the current major depressive or the most recent, if they're in remission, the most recent major depressive episode. So this is probably our first introduction to this in this class. When you give someone, or when you label the person with this diagnosis essentially in a clinical setting, if you make this diagnosis, you often are required to qualify it or specify it in a manner of ways. And this is one example of that. Within the major depressive disorder diagnosis, as I mentioned, you have to say single episode or recurrent. That's one sort of distinction you want to make. You then also will be asked to give a severity rating of mild, moderate, or severe. This is somewhat subjective. In our training, we learn to kind of look at what sort of types of symptoms are associated with all three of those. There are some pretty hard and fast rules. If the person is experiencing, pretty significant suicidal thoughts, intent, or plan, or has a suicide attempt, then we, almost always would associate that with a severe, major depressive episode. So you would give them the specifier of severe. You can say with anxious distress or with mixed features. With anxious distress would mean that the person didn't present quite as clearly as depressed, but had a lot of anxiety as part of that depression. The mixed features, as I said, can be a combination of a few symptoms, with melancholic features, with atypical features. All of these these specifiers are clearly defined in the DSM, but it's beyond the scope of this class for us to get into them. With mood congruent psychotic features, this is an interesting one. This is where the person may be experiencing, in severe depression, it's not entirely uncommon. It is rare, but it does happen, where people will experience hallucinations. Frequently, it will be auditory hallucinations. That is much more common than visual hallucinations associated with a major depressive episode. I have a very close friend who struggled with depression, who used to have episodes where he would have auditory hallucinations when he was really depressed. Mood incongruent psychotic features. So, the person might be depressed, but might be experiencing some sort of grandiosity in a weird way. So there can be some overlapping with some things you think of with mania. But this, again, very rare to see that. With catatonia, which is where you see someone who is catatonic, appears very distant and disconnected from reality, maybe uh, near impossible to get their attention, or they may appear like in a full state of catatonia, where they don't respond to stimuli at all. Another specifier is with peripartum onset. So this is after the birth of the child. Of course, I'm sure you've all heard of postnatal depression, postpartum depression, excuse me. So the idea is that it can happen in the midst of pregnancy or after pregnancy, in which we think is attributable to a lot of changes in hormones that pregnant mothers go through. There can be a seasonal pattern. Many of you may have heard of this term, seasonal affective disorder. Which is no longer in the DSM-5 as a diagnosis alone. You see it rather as a specifier for a major depressive disorder. But some people have dysregulation of neurotransmitters in the brain that are associated with exposure to sunlight, and so you might find that during the winter months they are more prone to depression. During the summer months, less, or maybe more prone to mania, or simply less prone to depression in this case. It's really fascinating, actually, some of the things we associate with sunlight and mood disorders. There is some interesting research that if you investigate people that live above the Arctic Circle, where they experience long periods of excessive sunlight and long periods of really minimal sunlight, the so-called white nights, kind of concept, when you have the sun barely ever goes below the horizon, and so you have almost continuous sunlight. What you actually see is an increase in manic symptoms. So there's some dysregulation of neurotransmitters associated with excessive sunlight, and certainly you see increased depression in those parts of the world where there are short days and long periods of night, which we think is related to, probably related to aspects of UV light. There are plenty of people who experience seasonal affective disorder of one form or another who will actually sit under UV lighting to try and alleviate that symptom, and there's some good evidence that it can succeed for individuals. And then finally, you have to talk about whether or not this the depressive episode is present at the moment, or if it appears to be waning and is no longer meeting full criteria, or is fully gone at this point, if we're between episodes, so to speak. So partial remission or full remission is another specifier you might make. What all this means is that when you give someone a diagnosis of major depressive disorder, it's not just that phrase. It's often major depressive disorder, moderate, recurrent. You might see something like that. Major depressive disorder, single episode, mild, in full remission might be another way you'd see this diagnosis actually included in somebody's chart. So that's major depressive disorder. Let's talk about persistent depressive disorder. This is a new diagnosis, a new term in the DSM-5, and is often one of the most confusing for students to understand. But what's really confusing about it is that the term persistent depressive disorder means any depressive mood disturbance that lasts for the majority of days across 2+ years. So as a result, there can be really different presentations that can accurately be called persistent depressive disorder, including, let's say, a person who experiences mild low mood lasting for years, a major depressive episode that lasts for years, or multiple major depressive episodes occurring against a background of more mild depression for years. But the idea is there's not really an alleviation. There is not really a period of time where the person ever seems to come out of at least some degree of depression. Now, this leads to a lot of confusion because this captures multiple presentations. This is why this is a new term. It's kind of capturing an older diagnosis as well as a lot of other possible diagnoses. So there are the basic overview, though, let me give you here, is that you have at least 2 years of depressive symptoms, wherein there is depressed mood most of the day on more than 50% of the day. So there's a lot of gray area there. There's a lot of wriggle room. No more than 2 months are symptom-free, and I think that's important. The symptoms can persist unchanged for long periods, in some cases 20 years. what we used to call, hundreds of years ago, a melancholic person, right? It may include periods of more severe major depressive symptoms. So the person might meet criteria for a major depressive episode at times and then go into these, as I said, mild or depressed periods. And it may be intermittent or it may last for the majority or the entirety of the time period. So let's talk a little bit about the kind of confusing various presentations you might see with persistent depressive disorder. So if you have mild depressive symptoms without any major depressive episodes, this is what we used to call dysthymic disorder. Okay, so this is now an outdated term, but essentially what dysthymic disorder used to capture is persistent depressive disorder with no major depressive episodes. So this is where the terminology and the lexicon can get a little confusing. What we would now diagnose that as is persistent depressive disorder with pure dysthymic syndrome. Okay, that's the terminology. So pure meaning there are no moments or no periods of 2 weeks or more where that person meets the criteria for a full major depressive episode. Rather, there is this long-term underlying mild depression they're experiencing. You can have mild depressive symptoms with additional major depressive episodes, which occur intermittently. This used to be called double depression, which sounds really ridiculous when you think about it. But the idea is that you were seeing evidence of both of these types of unipolar depression that were out there. In some ways, I think it might be helpful to think about dysthymia as sort of like hypomania. But it's often it's a much longer period of time that it lasts. But it is like a sub-syndromal or less severe form of, say, major depression versus a manic episode, major depressive episode versus a manic episode. It's just a mild presentation of those symptoms we associate with a major depressive episode. So that double depression is when you kind of fluctuate intermittently between the two. And then you may have major depressive episodes that last 2+ years. And then when it ever does remit, you're still going to be in this state of mild depression, and you're going to call that persistent depressive disorder with persistent major depressive episode, right? That's a full mouthful there. So I understand this is a little confusing, but I think if you kind of like try and graph out the possible combinations thereof of these various things, you're trying to capture the various different ways in which people can present. And so a taxonomy like the DSM, a language for understanding how we see these things occurring in the world based on empirical research, you want to make sure that you have labels that accurately capture what's going on with these patients. And this is an example of that. It's confusing because depression is so pervasive and so common in human experience, and it can manifest itself in a lot of different ways. And so this is the intent, to try and capture all of that. So this is the actual DSM-5 criteria for a persistent depressive disorder, aka dysthymia. I think that's a little confusing that that's still in there, right? So remember, we talked about what dysthymic disorder was, or dysthymia. Dysthymia is a state of mild low mood, is what it literally means. So depressed mood for most of the day, for more days than not, as indicated by subjective account or observation of others, for at least 2 years. In children, they cut that duration down to 1 year. While the person is depressed, they experience 2 or more of the following. You're going to recognize all of these symptoms: poor appetite or overeating, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration or difficulty making decisions, and feelings of hopelessness. So again, these are basically the same symptoms we associate with major depressive episodes. They are simply less severe. And if you notice, what's missing here, most importantly, is sort of the psychomotor retardation or agitation, as well as the suicide factor. During the 2-year period, one for children or adolescents, the person has never been without the symptoms in criteria A and B for more than 2 months at a time. That's that idea that it must be persistent. It must have very brief, if any, periods of being absent. Criteria for major depressive disorder may be continuously present for 2 years as well. There's never been a manic episode or hypomanic episodes. So again, we're trying to make sure that we are differentiating between unipolar and bipolar disorders. It also, you have not been able to meet criteria for cyclothymic disorder, which is again another one we're going to talk about in just a little bit. And this again is that rule out. Rule out is a term you see a lot in psychology. A rule out is basically you don't make this diagnosis if it fits this other diagnosis better. So schizoaffective disorder, schizophrenia, delusional disorder, or other unspecified schizophrenia, spectrum disorder, if the disturbance is better explained by those conditions, then you don't make a separate diagnosis. You just capture that under that larger diagnosis as an umbrella. Just a few other things to consider. Again, of course, not attributable to the effects of a substance, not attributable to another medical condition, same criteria as major depression, and it does cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. And then you have similar specifiers: mild, moderate, severe, anxious distress, mixed features, etc., etc. So, you can also, the one thing that's unique about this one is you can give a specifier to your diagnosis of early onset if onset is before the age of 21 years. We normally have some differences of how we diagnose for people who are considered adults versus non-adults. What I think is really important here is that this significant distress or impairment in social functioning is still required. There are plenty of people that the spectrum of their mood tends to lean towards the depressed side of things. I'm sure, again, you yourself or someone you know may meet that sort of description without it really impairing their functioning or causing them too much distress. There are some people that are generally more unhappy than happy, but don't cross this, albeit arbitrary, threshold we've established that it's not affecting their functioning and it's not causing them significant distress. Again, these are all specifiers associated with PDD here. PDD is the new abbreviation we're using for this, for persistent depressive disorder. Late onset if it occurs at 21 or older. So this is what I just mentioned earlier anyway. I'm just going over it again. Pure dysthymic syndrome with persistent, with intermittent major depressive episodes. So really just you're going to try and capture as best you can the specifics of the presentation of that person. I won't get too into the weeds on all these details though. So what are the possible courses of depressive disorders, right? There's a lot of different ways this can look, and these graphs that you're seeing here are just pictorial representations of the different kind of course configurations of unipolar or non-bipolar depression. I'm going to stay away from the term non-bipolar. I'm going to stick with unipolar. So the horizontal axis here just represents time, and the vertical axis represents the person's mood. So anything significantly above that that sort of 0 point there on the x-axis, if you saw if these blue lines were going above and beyond up top, we might be considering those sort of expressions of mania. So what you're seeing here is some different courses that might occur in individuals who are depressed. So let's look at each of these. Panel A is a non-chronic major depressive episode, in this case recurrent. So you've got 2 major depressive episodes, but in between the person's mood is essentially euthymic, which is the term for neither manic nor depressed. Normal, so to speak, if you will. I'm very careful of that word normal. I think that can be a pejorative in some ways to people that are experiencing these disorders, but let's call it typical, okay, average, if you will. Panel B is a persistent depressive disorder with pure dysthymic syndrome. So there's no serious, peaks, negative peaks, I should say, valleys that represent a full-blown major depressive episode. This is what we used to call dysthymic disorder. Letter C here is so-called double depression, major depressive episode occurring within the course of dysthymia. Panel D is a chronic extended major depressive episode, which may be captured by that PDD diagnosis for someone who is going through a very prolonged period of depression with no remission. Okay. Panel E is a major depressive episode in partial remission. So their mood has come back up, but has not completely gotten back to a euthymic state. And panel F is recurrent major depression without full inter-episode recovery. So this is just all the various different ways that people can experience their depression. And this is just, 6 examples. This by no means is exhaustive, and everyone's course is quite unique. As I've already alluded to, there's a lot of specifiers for depressive disorders when you make this diagnosis. These are just additional diagnostic labels that we use as clinicians to convey extra information about the symptoms. So for myself, as the provider for that person, it helps me to accurately conceptualize what's going on with them, but it's also very helpful for other people, whether it's someone who comes and does mental health work with this person after me, for their medical providers, for other people involved in their care. It's a more coherent and comprehensive sort of label or taxonomy to describe what's going on with them. So specifiers are not mandatory for things like insurance, whatever, but you're only supposed to assign them if they're appropriate. But for my take on it is, if you're documenting someone's mental health history, you should be as thorough as you can, because you never know who is subsequently going to, the patient may give you consent to provide those records to their next mental health provider down the road years later, and you want it to be as accurate as possible. There are a few that are a little confusing, and I went over these quickly when I was describing the DSM-5 criteria, so I'm going to hit each of these in a little bit of detail. There's the psychotic feature specifier. So some major depressive episodes also include some psychotic features, and you wanted to specify either hallucinations or delusions, and I've defined those already. The anxious distress specifier, which is where you have depression accompanied by several significant symptoms of anxiety. Long before my time, fortunately, being a psychologist, the term that was frequently used was a neurotic depression. Which was versus a vegetative depression. Neurotic depression is someone that was more anxious, worried, restless, ruminative, that kind of thing. Now, having depression accompanied by several significant symptoms of anxiety actually is a poor prognostic indicator. It predicts poorer outcome for individuals. It tends to be more difficult to cope with. I mentioned the mixed feature specifier, which is when you have primarily depressive episodes, but a few manic symptoms that are in there as well. Melancholic features is basically major depressive episode accompanied by additional severe symptoms such as early morning awakenings, or lack of reactivity to positive stimuli. People that become very numb, and this can maybe progress into catatonia in really severe cases. And as I said, catatonic features is the extreme example of that, which is extremely rare in depression. You see muscular symptoms where the person is kind of in a stupor, their face is very flat. You can move their body parts around and manipulate them, and they will stay in place. It's called waxy limbs. Some repetitive or purposeless movements. The person might be kind of just ambling or walking in a circle with no real intent, or kind of just doing something with their hands that is just sort of repetitive, that doesn't really serve any purpose. There are some atypical features. So as I mentioned, insomnia and lack of appetite are more common, but you do see hypersomnia, and you do see people that are overeating. I don't see the atypical feature specifier used very often in my clinical practice, but I do want you to be aware of it. Depression occurring around the time of giving birth is the peripartum onset specifier. The seasonal pattern specifier we mentioned, which is that depression that tends to occur primarily in certain seasons, typically winter. The term for this, as I mentioned, is seasonal affective disorder. What I love about that is the acronym is SAD. It's just a little too perfect. We think it's a result of this phase-delayed circadian misalignment. So the person's circadian rhythms are misaligned with the environmental day and night cycle, and can be treated pretty effectively with UV light therapy. So it's pretty cool. There are certain things that can be cured, simply by mimicking the effects of sunlight. I'm going to talk about the onset and the duration of depressive disorders, and then and we'll probably stop part one before I'm going to stop part one before I go into talking about bipolar disorders. It's rare to see full-blown depressive disorders in children. That does not mean that children don't experience sadness and loss. Of course they do. But we do know that it's relatively rare to meet full criteria for these disorders in childhood. But the risks increase in adolescence and young adulthood, then they decrease in middle adulthood and increase again in old age. There's sort of a U-shaped pattern associated with the typical onset of depressive disorders. They are extremely variable in length. So depressive episodes can last several months untreated. For some people, they may last several years. There was one sort of landmark study on treatment efficacy that was done years ago, and I don't want to quote it too specifically because I don't have all the details in front of me, but I do remember that the takeaway was that most major depressive episodes remit naturally within about 9 months. This was in the context of talking about, what's the best treatment for depression. And this is one of those findings that was not terribly popular with psychologists because it called into question, whether what we were doing was effective. Now, subsequently, there's been plenty of research, and that's why we have control groups that showed that treatments were much more effective than doing nothing, at least most treatments that are still dominant today. But we do know that it's the nature of the average presentation of depression that it does remit after a period of time on its own, even if the person doesn't seek treatment. That's just the typical course, but that, your mileage may vary. There's absolutely no guarantee that's the course that any individual is going to take. This is figure 7.2 from your textbook, which is these are Hamilton Depression Rating Scale, which is a diagnostic instrument for measuring the degree of depression someone's experiencing. And these are the courses based on those scores for dysthymic disorder patients with and without concurrent major depressive disorder episodes versus patients with non-chronic major depressive disorder over a 10-year follow-up period. So essentially what you're seeing is, just 3 examples of how people can manifest their depression and cycle both in and out of these episodes over time. Your book goes into extensive detail on this, so I won't go into too much today. So one thing that changed in the DSM-5 is how do we capture the concept of grief, bereavement. In previous editions of the DSM, essentially you were encouraged not to diagnose someone with depression during a period of mourning. We now know that you can meet full criteria for major depressive episodes as part of the grieving process. And so there's no longer that prescription from making the diagnosis, but I do think we have to always consider the context when making the diagnosis and what's normal, right? I will frequently, and again, I'm using the word normal to mean typical. I will frequently describe a patient as displaying symptoms of depression following the death of a loved one, commensurate with their loss, meaning that they are sad, tearful, they may have poor appetite, they may be sleeping poorly, but it is in the context of acute grief. So this is immediately after the loss. Integrated grief is sort of what we often think of as healthy grieving, the ability to come to terms with and accept and make sense of the meaning of a loss over time. Complicated grief is when that process runs afoul of or goes off the rails, so to speak. So this is when you continue to experience persistent acute grief with an inability to come to terms with the loss, when the person doesn't seem to be able to, quote unquote, get over the loss. And I'm very careful about that language because I really don't like that term. We don't stop missing someone, we don't stop reflecting on their absence, but the question is, are we able to process the feelings that come with that loss and make sense of them in a way where we can get back to functioning effectively? Okay, let's talk about a couple of other depressive disorders, and then I will end part 1 of this lecture, and I will see you again for part 2. But there are a couple of things that are new to the DSM-5, and I want to talk about them briefly. Premenstrual dysphoria, controversial diagnosis in the new DSM-5, but we define it as significant depressive symptoms occurring prior to menses during the majority of cycles, leading to distress and impairment, right? That's the important part there, is the distress and impairment. Why is it controversial? Well, short answer, tendencies of misogyny, right? The idea is that this is not typical quote unquote PMS or premenstrual syndrome symptoms, which are experienced by many women, in fact, perhaps the majority of women. Rather, we reserve this diagnosis for symptoms that are unusually severe. Sometimes they're numerous, persistent, and they really do interfere with functioning and can be distressing to the person. So you can see why this would be controversial, because there's a long history of misogyny in science. I'm not breaking any new ground by bringing that up. When the majority of the people who are dictating and developing the taxonomy are male, there is inherently going to be bias. That has, one of the things I like about working in the field of psychology is there's a lot of parity. In fact, there are more, women than men that are psychologists currently. And if you go to a clinical psych graduate program or to where I work at the VA, for example, I am in the minority, being a male psychologist. So that hopefully is affecting and decreasing that bias in the field, but it is still present, as it is in most aspects of society to some degree or another. But there are some advantages to including PMDD as a diagnosis. It legitimizes the difficulties that some women are facing when the symptoms are really severe. It basically allows them to be recognized and validated as having something that is outside the normal spectrum, that is problematic for them and is causing a lot of problems. But it also, on the flip side of that, the other side of that coin is, does it pathologize an experience that many consider to be quite normal and should consider to be quite normal? So it's controversial in that sense, and there was a lot of back and forth and a lot of discussion within the APA and amongst the American Psychological Association as well about whether or not this diagnosis should be included. And I think that there were proponents for both sides of it, and the eventual discussion was driven by the science and the research. And they looked at lots of clinical examples and research that differentiated these people in terms of their distress and their functioning from other women that were experiencing, what are largely considered to be normal symptoms associated with menstruation. So these are the actual criteria from the DSM-5 for premenstrual dysphoric disorder. You have to have at least 5 of these symptoms present during the final week before the onset of menses, and improves days after onset, and minimal or absent in the weeks post-menses, right? So it has to be eligible for this diagnosis, to meet this diagnosis, the person's presence or absence of symptoms needs to follow the pattern that one would associate with the hormonal changes as part of menstruation. So mood swings, sensitivity, etc., irritability or anger, depressed mood, anxiety or tension, decreased interest in usual activities, aka anhedonia, difficulty concentrating, lethargy, change in appetite, problem sleeping, feeling out of control, or physical symptoms, including pain, cramping, those sorts of things. So what you've got here is some symptoms that we may typically associate with more traditional PMS, but certainly more extreme. But a lot of symptoms we associate with a major depressive episode as well. So this is why it falls under the category of depressive disorders. Let's move on to one other new diagnosis in the DSM-5. Disruptive mood dysregulation disorder, which I agree is a mouthful, is a new disorder that took the place and captures better a previous diagnosis, which was called intermittent explosive disorder. There is not a formal diagnosis for having an anger management problem, essentially, but this does a job of capturing that pretty well. And so I think it's useful because we had plenty of interventions in psychology for anger management, but we didn't have necessarily a specific diagnosis that seemed to capture it, besides intermittent explosive disorder, which was I think was not as good as this. What we're seeing here is severe temper outbursts occurring frequently against a backdrop of angry or irritable mood. It's diagnosed only in children 6 to 18, so you still have this idea of adults who manifest these symptoms, but for the purposes of this diagnosis, it is only applicable to children 6 to 18. You cannot meet the criteria for a manic or a hypomanic episode, so that extreme irritability is not in the context of mania. And this was designed in part to overcome the overdiagnosis of bipolar disorder in youth. Now, when we get to, in just a moment, we're going to talk about bipolar disorder, and I will talk more about misdiagnosis. But just briefly, I'm sure we have reached this point of saturation in our language where the word bipolar or bipolar disorder has unfortunately developed a connotation of someone who has difficulty managing their anger. I've had plenty of patients tell me, oh, I've got bipolar disorder. And when I ask them what they mean by that, they say, I can just fly off the handle at a moment's notice, which, yes, irritability is part of mania, but fails to capture a whole heck of a lot of other symptoms we associate with bipolar disorder. So there's in children that are displaying angry outbursts and temper tantrums and even violent outbursts, who are always angry or irritable a lot of the time, there was a tendency to say, oh, irritability, and reach for that diagnosis of bipolar disorder, including a lot of medical treatment, including medications with some potentially dangerous side effects, especially potentially dangerous side effects on brain development. So this diagnosis was thought to better capture a syndrome that you see in young people, and to avoid them being misdiagnosed and potentially mistreated as someone who has bipolar disorder. So I'm going to end there for part 1. And in the next part, in part 2, we will talk more about bipolar disorders. We'll talk about some general issues regarding treatment of the various depressive disorders. And then finally, we will talk a little bit about the phenomenon of suicide and when and how it tends to occur and how it's treated within the context of abnormal psychology. I'll see you then.